Good afternoon, everybody, and thank you very much for joining this webinar. So, as you all know, we're going to be talking today with Charles Cross from Ashley Care and talking around what they've been up to in the last few weeks in terms of, or last few months, I should say, implementing Fall's response to their clients. Now, we're going to be learning about what was happening before, the impact that that's had, and then subsequently some further thoughts to be shared regarding the industry as a general piece. So I should have said initially, my name's Grant, and I'm going to host this session, and we'll try and keep it within the hour. And the rough agenda as such is we're going to be hearing predominantly from Charles and then Kerry, the registered manager, talking about what they've been up to. And then I'm going to be doing a live demonstration on both the Raizer and HelpFall, which are a couple of the pieces of product that Charles and his team have been utilising. And then we'll be going through a question and answer session. So just keep the questions flowing throughout the session. If you can just pop them in the chat or the Q&A section, and then we'll loop back to them at the end and go through them individually, try and answer them all live. So just before I hand over to Charles, who can introduce himself, it probably helps to give a bit of context as to Felgains and, why are we dabbling in this space. So we, as a company, have a vision, and we genuinely believe that it's entirely possible to eliminate all ambulance callouts to minor and non-injury falls. And I guess the reason we're now talking about domiciliary care or home care is that the clientele that these organisations will typically provide care for are more prone to falls, and subsequently they experience a vast proportion, or not a vast proportion, but a large number of the falls that happen within the community. Obviously, you've got care homes, you've got people that aren't having home care, you've got within the hospitals, believe it or not. So there's so many different areas where falls are a problem, and we're just honing in today to look at home care and what can be done about it. So, Charles, I'm going to hand over to you. You can take us away with an introduction and maybe share your screen. I think you've got a bit of a presentation.
Yeah, thanks for that, Grant, and good afternoon, everyone. Charles Cross, Director of Ashley Care. And as Grant said, we met last year, and one of the key problems that we had within our own organisation is we frequently had people that were falling. And again, they did classify under that non-injurious or minor injury falls. So I am going to share my screen and have a bit of a presentation, and that's going to give an overview of an 8-week pilot study that we completed within Ashley Care. Subsequent to this study, we have been collecting data since mid-December last year. So we have over 12 or almost 12 months worth of data at this stage. So we can share some more up-to-date information for anyone who's interested. And what I can say is the numbers that you'll see within this presentation can be extrapolated out. And we've had that same frequency of falls and impact on both our service, but also more importantly, the wider health and social care sector in its entirety. So as I previously said, we did an 8-week pilot study to try and find out what the impact of this technology could be. And why did we do this? We found that increasingly, due to winter pressures, the ambulance wait times were increasing. And they were specifically increasing around non-injurious falls and minor injury falls. And we experienced wait times beyond 7 hours, 10 hours and more. And we felt that we could do more in order to help solve this issue and also relieve pressure. I think everyone within our service, if we're working within health and social care, have experienced this challenge. The service users that we care for fundamentally don't enjoy falling, and they also don't enjoy having to wait on the floor for an ambulance for multiple hours. And if our care has them at the heart of it, then we need to do more than just accept that there's going to be additional wait time for those individuals. So as you can see on a broader macro point, the falls are estimated to cost the NHS more than 2.3 billion a year. a fifth of elderly people who are admitted to hospital after they had a non-injury fall, who have been left on the floor for more than 1 hour. And this is a key part of this, is if someone's waiting on the floor, then the chance of them being admitted to hospital is much, much higher. And then it's not just the case of that person being admitted to hospital, but it's then that person being cared for in hospital and then subsequently coming out of hospital with increased care needs. So over and over again, we found that people were in this fall cycle where they would have a fall, there would be an ambulance wait time of extended amount of hours, which resulted in a long lie. And that's just due to the system-wide pressures. This is not to point blame or to identify any bottlenecks within the system. There are bottlenecks within the system, but this is just because of the levels of demand we're experiencing, especially within those winter times. So it's how can we be proactive? How can we be innovative? And this is really a solution that we put in place, and then I'll speak to some of the results. So once someone had a long lie, then they'll have hospital admission. There'd be careful inpatient, outpatient care. And then increased care needs. And we found that time and time again, where there would be a decrease in mobility, increase in frailty, and that would mean that these people would need potentially double-handed care, or certainly more visits per day, especially for a period where they would come out of hospital. That there may be a reablement period, and then that person would have a decrease beyond that. And then more broadly, is when someone's had a long lie, they go into hospital. Again, there needs to be assessments done for that person into hospital. There'll be a cost to the system there. There's obviously a disruption to the system there. The person, again, fundamentally at the heart of all of this, isn't enjoying this process, because then they're having to be reassessed when they come out of hospital, potentially reassessed with any reablement package, and then potentially reassessed for any mainstream care that's being delivered. So that person is being passed through the health and social care system when that can be prevented right at the source. So it's really, how do we prevent that at the source, and how do we stop the fall cycle? These are some of the costs to the wider system that we put within this study. These were on the gov.uk website, and this is basically highlighting the cost to the system when we're not using an innovative solution such as the Raizer chair and the HelpFall app, and then the impact that's having on a financial perspective. Grant, we're lucky enough to see the Raizer chair in action today, so I won't touch too much on how the Raizer chair works. We've got the automatic electronic model. So again, it's extremely easy to use, easy to put together. The Felgains team came out, trained our team. They felt extremely comfortable in using it. It is a case of a remote control. I know there is another leverage model, so you'd have to look into that. But we find it extremely easy to use. The team are completely confident in using it. And what gives them even more confidence is the use of the HelpFall app. I think one of the situations that we find ourselves in is really a confidence situation. Are we sure that this person is safe to lift? And in many cases, we may know that, but it's not only about having the HelpFall Assessment app, which has been put together with South Western Ambulance, NHS Foundation, and also it draws on the latest guidance from NICE and the National Patient Safety Agency. So again, this is backed by the latest guidance. Our team is easy to use in terms of the questions that are asked, and then the answers is via a traffic light system. And one of the important factors of using the HelpFall app is the fact that we can then gain the evidence. So we can have the evidence sent straight to us that this was a non-injurious fall or a minor injury fall, and this is the reasons why we decided to pick the individual up from the floor. And this is important for, as I say, the evidence base, and then for us to have a process in place. So each individual organisation will need to have your own process in place, and that's something that we can assist with. You're more than welcome to reach out on how we do that. And because there's a Raizer chair, you're also going to have to look at how do you logistically structure to make sure you have your Raizer in a central location. I think the mission by Felgains is completely admirable. And I think we've discussed in the past why Raizer chairs aren't as accessible as defibrillators. and why don't we have them more widely available? Because this technology is something with the right guidance, such as the HelpFall app, something that can be more mainstream and widespread, because the impacts which we'll get to are conclusive. So this is just a snapshot with no personal information, but a snapshot of the data collection that we took. And this was essential for us in order to build our own evidence base, not of the falls, but the evidence base of the impact, because we wanted to track whether this was improving. I think that having heard of the Raizer chair and previous deployment, you look at care homes, you look at fixed settings, but ambulances often do go out into the community. And we're in a unique position when you have a community-based service that you can access people's homes, and you do access people's homes every single day and often multiple times a day. So you are already out in the community, you're already there to assist, and often, dependent on the policy of the individual local authority, you're having to actually wait with the individual until an ambulance arrives. So if to touch back on a point of the wait times and then what happens preceding that, our team could have to be in with an individual, ensuring that they're comfortable, ensuring that they're safe for 10+ hours, when a solution such as Raizer Chair could relieve that operational disruption, and mean that we could pick someone up within half an hour, and then we can carry on with the rest of the service users that we're due to care for. And I don't think we can get away from the benefits this brings to the individual. We may talk of, how this affects our business, how it affects the wider system, but again, we have a large quantity of qualitative data of people's opinions, and they really enjoy the fact that they don't have the stress, the panic, the anxiety of having to be put through the system, because they're going to be on the floor for multiple hours, then they're going to be conveyed to hospital, etc., etc. And often, just like you and I, they just want to be at home. They want to be cared for in the comfort of their own home. So a solution like this really allows for that to happen. So within the 8-week period, we attended 21 falls. I should mention that we have both a home care service and we provide a Southend City Council's telecare service. The home care service had 10 falls, and we managed to raise 6 people out of those 10 falls. And we do follow up with UCRT, but only where UCRT then had an action was only 2 of those. But we do follow up. We do follow up every time there is a fall. And again, the multidisciplinary work, the work with other healthcare professionals, the GPs, is essential when we're taking this step as a social care provider. And if there are other social care providers listening to this, it's going to be essential to make sure that we are linking in with everyone to ensure that there is an update. And often there's a reason for a fall. Sometimes it can be an inconspicuous reason. It can be just because someone tripped, but sometimes it can be due to vitals. Sometimes it can be due to people's health. So it's essential that when we're taking this step to provide this solution that has the person at its heart, we are also linking in with other healthcare professionals to ensure that they're informed that a fall's taken place, so that any follow-up that may be required is happening. And that's again essential, and that can be put within your own policies, and you can touch base with Grant or I after the session if you want to find out a bit more about how we work multidisciplinary. And again, within our telecare service, we had 11 falls and we picked up 91% of people. So what you'll see within these statistics is everyone who we're not picking up is being conveyed to hospital. So there isn't a middle ground. It's the person is the HelpFall app gives you that clarity. It gives you that distinction, a clear whether you should pick up or whether you shouldn't. And in the times that we shouldn't, they're conveyed to hospital. And in the times that we should, we've evidently picked them up. And the 91% within our telecare service is a huge impact. And we've, as I said before, we've seen that data, that frequency of falls and the frequency of picking up and the percentage, we've seen that pretty consistent over the last 10 months or so. And in total, you look at a 76% reduction in ambulance callouts. So of our whole service, we're now picking up 3/4 of the individuals who have fallen. And as you can imagine, that is a huge cost saving, as you can see in this slide, but a huge impact on the individuals. And I think, again, going back to that, but within these costs, and again, I can share some of the formulas behind all of the cost savings, and Grant and I can touch base with any people who are interested in that after. We found that there's a £44,000 408 cost saving to the sector and the wider system, and that's put through both the NHS, Southend City Council, and Ashley Care. And I think the focus as well is within all of this, these costs and the increased care provision, it's a benefit to us as a company in terms of being proactive in handling this. But it's also acknowledged now by the council that there's a benefit. And if you're a care provider, it's important that within the communication of trying to adopt something like this, you then link in with your local council or local authority and your ICB, because there is huge potential to expand out the scope of this. And this is an innovation that clearly within the last 8 weeks that we did it, but then the last 10 months is pretty proven. So the benefits to Ashley Care is we were recently within the CQC report as well as FEL gains, and that was capturing innovation to accelerate improvement. Grant and I did a roundtable with the CQC, and we met quite a few like-minded people. As I can imagine, if you're in this webinar, you're one of those like-minded people who are looking at how you can innovate, how you can think differently, and how you can tackle these issues. So we had a great conversation there, and then we were fortunate enough to be included within their report about how we can think differently and how we can implement innovations. And I think within health and social care, we discuss innovations, and sometimes they're far-reaching, sometimes they're difficult on a technological adoption perspective. This solution's unique in the sense that it's ready to be implemented within your organisation. We implemented it within 2 weeks. We had the training, we had the HelpFall app. We ensured that everyone was comfortable, competent, and confident. And then we put this in place and saw the benefit. So again, this is something that can be adopted relatively quickly, and you can be ready for potentially winter pressures this year or just your service in general. Second of all, there's clearly a prevention of hospital admission leading to care being delivered at home. This doesn't disrupt your service if you're a domiciliary care provider, because your service just continues as usual. I think the individual going back to it is at the heart of what we do. So that's a benefit to them. It's a benefit for your team because you're not waiting. It's a benefit to the wider system as well. And that operational disruption. Again, we have one Raizer chair in a centralized location and one Raizer chair for out of hours, and that's kept with the person out of hours. And the time it takes for us to react and respond to a fall, and often we're notified of a fall when we actually are out delivering care, or we have a telecare call out, and that's via a care line pendant. We find that we can respond within half an hour. Whereas the alternative is these people may be on the floor for much longer. So the operational disruption is really within half an hour, and then we can have that problem solved. We need to then link in with the relevant healthcare professionals and ensure that work's done. Sure, with evidence the fall and potential reasons for the fall, and then we can move on with our service and care for the other individuals within our service. The impact of the team, Kerry can speak to this, but it's career progression. It gives your team an opportunity to be able to develop their skills and really have a positive impact. And I think when we certainly do our staff surveys, and wanting to be in care, the vocation of care, wanting to help people within our service is an important part of what we do. And we don't want to feel the helplessness that unfortunately someone's on the floor and there is nothing we can do. So this really allows us to be fulfilled in the sense that we can actually respond to that situation. And what underpins everything, as I've mentioned previously, is the HelpFall Assessment Tool. And this really gives our team the confidence to ensure that we're lifting at the appropriate times. And that's clearly the distinction. And then people being cared for in their own homes, and I'll always go back to that. Some of the quotes from the Ashley Care team, that it's a fantastic piece of equipment, so beneficial for the clients. It saves them having to wait on the floor for an ambulance for hours and hours and so easy to use. I can remember being so excited when I was made aware we were getting this piece of equipment. It's amazing. It's empowering to be able to help someone and prevent them for having to lay on the floor for hours waiting for an ambulance. It's easy to use, assemble and transport. It's really beneficial to me as a responder and to the client. So again, this sort of reiterates some of the points that we were discussing previously, and we have some more quotes both from the team but also from the service users, and again you can touch base with Grant. So an overview of our 8-week pilot and then beyond is we did have a 76% reduction in ambulance callouts with a 91% reduction in the telecare callouts. If you extrapolate out the £44,000, we're saving £288,000 to the system. There's a prevention of 2,912 hours of annual additional care. And that's really around the increased care demand that we see when someone's admitted from hospital. And that may only be for a brief period of time due to reopenment, or that may be due to permanent mobility decreases or increases in frailty. You may actually see that care demand being more long-term and permanent. And then fundamentally, we're trying to break the full cycle. So thank you. I've put Grant's contact just down there. He can pass on my contact details if you wish. Please do take that. If you've got any questions, then I'm sure we're here to answer it just after Grant's brief demo.
That's really interesting, Charles. And I think it'd be fair to say, as having worked with a number of different industries, we should point out that this is a really innovative approach. I mean, from my point of view, Charles could have said to me, I mean, I know Charles reached out to me initially, but just hypothetically, Charles's approach could have been that, you know, this isn't our problem. We are just on the receiving end of system pressures, and subsequently, you know, it is what it is. And what I really love about this whole concept is that we're actually looking more holistically. Charles touched on throughout that presentation the impact that it's made to every different area, both to the individual, to Ashley Care, and then to the system itself. Now, I'm sure if my understanding of the market is anything to go by, there's probably quite a few questions in terms of, you know, the nuts and bolts of how you work this out. And so it'd be good to see the chat box start firing up in terms of questions. I'm gonna just touch on using HelpFall and the Raizer and just talk you through that, and then I believe we're going to be hearing a bit more from Charles and Kerry in terms of answering some of those questions. So you can see on the screen now HelpFall. Now HelpFall we designed with Southwest Ambulance Service, and the background to it was having access to a piece of kit to lift somebody from the floor is great, but if the person that's supposedly meant to be responding to the fall doesn't feel confident, then it's, in one sense, a complete waste of money. It goes dusty in the cupboard. So we reached out to Southwest Ambulance Service to figure out, you know, what could we be doing about this. Now, they had a post-falls decision support process, and we've worked with them to effectively turn that into a digital tool. Now, the whole brief behind this project was, let's create something that allows a non-clinician or a carer, anybody, to assess whether the person is better left on the floor or lifted up. So in terms of accessing it, Ashley Care have got their own access code, which you type in there. So on the Raizer chair, it's got a QR code. You scan the QR code with any device, it brings up HelpFall. You put in your access code and press validate. I haven't got a keyboard in front of me, so I'm hoping it's saved. It has. So as you can see, it's typically used on a portrait device, but we'll work with it and we'll just crack on and press start. So it works on a traffic light system, as you can see on the top left, red for major injury, amber for minor, and then green for no injury. It works very similarly to the NHS 111 service and the questions you'll be asked. For the purpose of this, we may as well take a scenario. So let's say that the client falls out or slips out of the Raizer recliner, and on the way down, she maybe catches her arm on over chair table, and it is bleeding. So we're now, as a carer, is this person conscious and breathing? Yes. Does this person have severe or uncontrollable bleeding? So it's well, they are bleeding, but we've got a helpful hint here. Bleeding which will not stop or slow down using direct pressure. So the answer to that is no. And then we're then checking for those other symptoms for that spinal injury. Again, trying to be really clear as to what we're actually looking for. A new central neck or back pain, repeated vomiting since the fall. So the answer to that is no. And then moving on to looking for signs of having had a heart attack. And again, we've got the symptoms that a heart attack will present. So no. Is the person showing signs of having a stroke? Got the FAST test, which everyone's familiar with. Now, just for demonstration, I'm just going to move away from my example just briefly and press yes. So let's say that they are showing signs of a stroke. You'll see here that the advice is do not lift the person, call 999, give first aid, and consider making the person comfortable. We'll skip back to where we were. So showing signs of a stroke, no. Is the person showing signs of a hip fracture? No. Is the person showing signs of having a fit or seizure? Now, this is the last of the major injury section. So if we press no, it then moves on to minor injury. So from here on, the advice is to lift the person. So does this person have any of these symptoms? Yes, they actually do have an injury to the arm. They've got a new cut. So we'll press yes. So the advice is, well, give first aid as needed, lift the person from the floor, and then really crucially, contact that GP or that locally agreed provider for advice. So the whole background to this is that person, is the best thing for that person for them to be left on the floor waiting for an ambulance or lifted up. It's not saying that Ashley Care can provide all that follow-up and wraparound care and service. It may be that we do need to refer them to some other locally agreed community provider. I will just carry on so that you can see the rest of the questions. So we've done any of those minor injury symptoms, and then we've got the anticoagulants, which is a very interesting one, often gets thrown in. Now, I should point out that all the clinical guidance from this is directly from the ambulance service. We've merely turned it into a digital tool. So we'll press no here, and then you've got through to the minor injury, no injury. So if we press a complete report, and this speaks to what Charles was saying in terms of that visibility, we can now put in a client reference, be that initials, postcode or house number, date and time of the fall, which will automatically populate. And then we've got location of the fall. Got a few of those just sort of headline figures that get you thinking, why is the person fallen? What else do we need to do? And it gives a real good bulletproof reference guide if it ever was to be challenged. So let's say you lifted somebody, everything appeared to be okay, and 2 days down the line, it becomes apparent that actually they have sustained a more major injury. Well, be it you or be it a paramedic, they're not going to have been able to assess that. Nobody's got X-ray eyes. So the point being, at that point in time, did you do the relevant checks? And here is a snapshot that, yes, I carried out the relevant checks, I followed the guidance, and then this is what it told me to do. So we can put in any email address. I'm just going to try switching over to the report it will then send. So once we've put in the registered email address, we can then press send the report, and then it will ping through a copy here. So this is just a example, but as you can see, it's a snapshot which comes as an encrypted PDF, which can be uploaded to the patient records, can be sent on to the GP, and then you've got everything, one piece of paper, which is then a reference guide from there on. And that can, depending on how serious you are about this can really start driving some of that falls prevention work. We're looking at, okay, this person's falling really frequently. Do we need to refer them to a full service? Is there something more major going on here that needs assessing? But again, coming back to that fundamental thing, are we acting in the best interest of that client, making sure that they're delivering or receiving the best care? So again, maybe some questions pop up on HelpFall, but I'm going to move on to demonstrating the Raizer chair. So I totally get that when somebody falls, they don't fall in a nice open space like so. They will fall in a confined place up against a bed or down next to the toilet. But what we're working with is we need to move that person. Once we've done HelpFall and found that we are okay to move them, we move them into a position where we can use the Raizer chair. And I'll do that right here. So the Raizer chair comes in 2 different packages. And I was just talking to Charles earlier. I think when I went and trained their staff, I didn't tell them how to use it. I just said, lift me up, as a proof of the fact that it really is very simple to use. So, Ruben, maybe just adjust the camera slightly. That's it. And in here, we've got all the different lifting components with a really simple guide as to how to actually use the Raizer chair. And then in here, we've got the main seat unit. So let's get Ernie on his feet. So we've assessed him using HelpFall. He's okay to move. And then we're just going to go through the process of actually using the Raizer chair to lift him up. So if I just ask you to bend your knees for me, like so, and then we're going to slide this seat unit in there like so. And then in the backpack here, we've got all the rest of the different components, 2 backrests and 4 lifting arms. So this can be done by one person, and I'll demonstrate how. So Ernie, if you can just cross your arms for me, like so. And then I'm just going to ask you to look towards the camera and roll away from me very slightly. If needed, I can provide some additional support, encouraging him to roll. And then let's work on the assumption that maybe there is actually a bath just here. I'll do it from here. Just roll Ernie towards me, like so. And each time we're putting in one of the parts, it's giving us a confirmation tone. So just got the 2 more. We'll put this one in. And then when we put the last one in, it's going to make a slightly different noise. Gone green, which means we're safe to lift. And then the remote control, which is housed in the side of the unit, we pop that out, go around to the back of the client, support their head, and then it's simply just a case of pressing and holding the up arrow. So you can see from here, there's nobody else helping me. I'm not taking any weight at all. It's just merely a case of reassuring the client. And then dependent on the height of the individual, you can stop at any point to then help them to mobilize away. So in this case, I'll bring Ernie right to the top. So you can see it's quite a high perching position. And then maybe with the support of some walking frame or something, you can then assist the person to stand up. Thanks, Ernie. Very ably demonstrated. So that is the Raizer in a nutshell. I guess there's a few questions that have come up here, and Charles and Kerry. Maybe Kerry, actually, first, you may be wise to introduce yourself before we start firing questions at you.
Hi, I'm Kerry. I'm the registered manager at Ashley Care, and this piece of equipment has just really changed the way we work, the ability within the team to respond to people on the floor. So yeah, hopefully I'll be able to answer your questions today because I use it quite frequently.
That's good. I'm sure you can talk to some of the real life examples in due course as well. So I've got a question here. Are all the staff trained to use the equipment, or is it an on-call team?
Yeah, so we now have 2 chairs, which is really beneficial. So we have one in our central office for the daytime, so anybody can respond that's been trained, any of the office staff or managers. And out of hours, because we deliver a service 24 hours a day to telecare, which is connected with Careline clients, it's ideal that you have the chair with a trained person that is working out of hours. If it goes to the care team, they may not be able to respond quite as quick because they might be dealing with a care visit. So in answer to that, we do have it with our senior response team.
That's good. And this is a really interesting question here coming from Jamie. I kind of anticipated that something of this kind may come up. So Jamie says, thanks for the great presentation. How do you charge for call-outs to use the service, Charles?
Yeah, it's a great question, and one that Grant and I have discussed. With regards to the impact on the commercials for this for our own organisation, again, there is no commissioning of this at this stage. I think this is an aspect that we're going to have to lead. We're going to have to prove the effectiveness. We're trying to do that within our case study. Currently, within our telecare service and our domiciliary care service, we will be paid for our time. We won't be paid a surcharge or any additional benefit that we're providing to the system. I think with the integration agenda, I think with the integrated care systems, you're seeing this change. I think you're seeing a lot more collaborative work between organisation and between health and social care. So I think we need to lead the charge with doing it. I think we need to lead the way. I think we need to gain the evidence base, and then we need to put this to commissioners to say, look, this is an integrated service and this can be a real benefit. So to answer the question bluntly, there is no additional payment at this stage. But I'm hoping with people on this conversation and speaking about this more broadly, we can change this both locally and then nationally as well, because social care providers can do more. We often do an incredible job, but there's always more that we can do to provide benefit, especially when the whole system is feeling the pressure of increased demand.
Yeah. A really interesting point. I think if I will just like, it would be great, and I think that in time we'll maybe move to more of that, where it's a commission service, or we're being paid to offer that additional service. At this point, I guess what we're having to focus on is the impact it is having on the business from a logistical point of view with the care scheduling, and also the value that we're providing to those people on the floor, which I guess fundamentally is the crux of the business. Charles, any more to comment on that?
No, I think they're just the people aren't being conveyed to hospital. So again, in terms of your own business, you're caring for people in their own home, so you're continuing to care for someone in their own home. So I suppose there's a benefit for everyone in doing that. But no, I think webinars like this, I think some of the work we've done with Fell Gains, again with the acknowledgement with the CQC, hopefully this can evolve over time.
Yeah, that's good. So this was going to be a question I was actually going to ask out of curiosity to figure out what kind of caseload you have. So question here from Sarah Pearson. So is there an indicative caseload size per Raizer chair?
One chair, we can look after up to 200 people, and then we have telecare clients. And one chair at the moment has been adequate. We've got the second chair because it did prove that we could be in one place and then get a call out to another person. So hopefully that answers your question. But yeah, one chair, depending on the size of your service and how far you're going to go with this, hopefully we'll be able to put this across to all of our clients so that they know that we have this chair. That's our intention. We may need more in the future.
Yeah, and I think the other thing to bear in mind is the geographical area in which somewhere may cover. Because if you've got a Raizer chair, within 5 miles of a client, that's great. But if you're providing care miles away from your hub, well, then you need to think about, is that something you can actually offer?
Yeah,
now, there's a question come through, which is probably more for me. Who would be the responsible organisations to carry out the Lola inspections for the specific equipment? Now, weirdly, the Raizer chair does not come under Lola, so that in itself is not a requirement, but it does require an annual service, of which it would be the responsibility of Charles at Ashley Care to pay for, which is £179. How would you roll out the training to use the chair? I could talk to how Felgains do it, but maybe Kerry, you could talk to how we did it.
Yeah, so the group of seniors that could attend the training in the beginning, Grant, he came in to do our training. We was all like, oh, we don't think we'd be able to use this. And it was so simple, and he made it so easy to put the chair together, to explain how to use the remote control on it, how you support somebody, because it's not just about lifting them up on the chair and that's it. You've got to reassure them, let them know that we'll be using equipment, support their heads when they're coming up. And we found it really simple. It's been able to be rolled out amongst all of our seniors and managers now, including our trainer. So yeah,
Yep.
And it takes probably about half an hour to an hour, if that, because you learn about the HelpFall app too and how to use that and the QR code.
Yeah, I would just comment that we really do emphasize the need for training. I mean, it's all very well having a piece of kit, but if the staff don't know how to use it really confidently, then you're kind of wasting an investment. So the typical, and we've made some changes since the rollout to Charles, but typically how we would do it is some form of trainer session, which is certificated, and that the people that have then been trained are then able to pass that and disseminate that information on to the rest of the team, and they're supported with a whole host of training resources online, both videos of how to deliver the training session, but then also how to use the Raizer chair, how to use HelpFall, and then competency checklists and things like that. Do you have certain residents who you wouldn't consider using the Raizer with, e.g. people who are very confused? I could probably give you the textbook answer, but Kerry, go to you.
No, I don't think confusion, as long as you can assure somebody and the HelpFall app has recognise that they can be lifted, as long as you can reassure them. If they become agitated, then we wouldn't do that, because it wouldn't be fair on them if they really couldn't understand what we were doing. So I think you have to, although you can use the app, you've got to really use your knowledge of people and know whether they're going to be okay to be lifted using the equipment, because I suppose it can be quite scary for some people. We haven't come across anyone that we can't use it or haven't been able to use it so far with confusion, only with weight restrictions.
Which actually moves on to John's next point, which is, does the Raizer chair have a height or weight limit? And the answer to that is yes. So 150 kg, which translates to 23.6 stone, I believe. Height limit? No, not a textbook answer to that as such, albeit probably less relevant in this industry, but sometimes children will be called out to do some form of falls response for that. And that's a slightly different one, because obviously this is built to your standard dimensions of a typical adult, and therefore you kind of, again, with everything pretty much in care, you have to risk assess it. You have to kind of use a bit of common sense, like, is this going to work? Is it not? And I don't know that we can necessarily be too prescriptive in the answer, unfortunately. So yeah, there's no more questions on the chat, but Charles, I did just have a question for you, and Kerry actually. Let me just put it up because I made a note of it before. So, Charles, this is one probably for you. What do you feel the biggest barriers are that are stopping more people adopting this innovation and it being more widely used?
Yeah, we've discussed this before, Grant. I think that it's multi-pronged. Initially, one of the questions here is how do you benefit as a provider in terms of incentive, and is this being commissioned? That's going to be a huge step forward if commissioners can support an innovation like this and see the benefits and acknowledge the real-time data that we've got, the quantitative data that we've got, and the qualitative data that we've got of people's experience of using it. I think there's a culture of innovation that we need to really harness within social care. You're seeing a lot of developments within digital social care records, and different technologies with virtual reality training, etc. And I think that this is another technology, this is another innovation, that forward-thinking care providers who are thinking beyond what their core service is can really adopt this. And that will initially be at the benefit of the service user, but then this will obviously translate across to their service and the wider system as well. And the more that we can do this, the more that social care can really push to be a service that is on parity with the NHS. We're assisting the NHS, we're assisting the ambulance service, and we can really come together with the integration agenda as one sector that is really there with people at its heart and caring for them. So I think culturally, we may in the past be slow to adopt some innovations. I think we can be progressive. I think we can be proactive. I think where there is the data to justify it, then we can be maybe slightly quicker in terms of adoption. And again, we've touched on a few points before around the willingness to actually lift someone from the floor. And the willingness is both around some people with the discussion around insurance, and again we've notified, but there isn't fundamentally too many difference between lifting someone within hoist that we use every single day to using a Raizer chair. There is really not too much difference. They go in bed to suspended within a hoist, and this is going from seating to standing, all supported along the way. So again, with the right technology, with the right digital tools, with the HelpFall app, that should improve people's viewpoint. And with the demo today, you can definitely see how safe and effective this sort of technology is. And then further to that, why don't think it's been adopted? I think there's always a point within organisations where you have to adopt, and Kerry's done a phenomenal job. Christine has done a phenomenal job, both registered manager and nominated individuals of Ashley Care, of really driving the adoption of this. Of really, as soon as we have a fall, there is straight away the process. Look, we look to pick this person up. We look to assess whether this person is appropriate to pick up. And through their leadership of doing this, and within your own organisations, you'll have to pinpoint the people who can drive this adoption so that it is the first reaction when we have a fall. And always, if you then have those small wins where you're able to appropriately assess someone and then raise that person from the ground, and then you get that feedback from that individual and so on, it becomes a snowball effect where you're really improving the lives of the people, but then you're also getting the fulfillment within your team. And Kerry can probably speak to this, but we've definitely had that in our own organisation. So culturally, in terms of adopting it initially, then the rollout, but then I think there's a broader picture of what the system needs to do potentially to acknowledge the work that we've been doing.
I haven't got anything additional to add to that. I just 100% agree. So much of this is cultural. Kerry, what about you?
Yeah, it's just been one of the best innovations we've had, I think, at Ashley Care. I used to dread a phone call coming in to say, I've just got into my client and they're on the floor, because I didn't have the resources to send a care worker, a senior personal manager to wait for several hours. In some cases, it reached 12 to 19 hours. And the impact on that, on our delivering of our service, was just immense. The chair has resolved all of that. There is still the occasion where we have to wait because somebody does need medical treatment, and that's the right thing to do, but it's very, very minimal now. So yeah, the benefit of having it. What I would also say is what you said earlier, Grant. People don't always fall in a conventional way where you'd like to find them on the lounge floor on their back. And we learnt very quickly, actually, we need a slide sheet in our bag with our kit, and Charles bought us a transfer board. One of the first calls we got at about 3 o'clock in the morning when we had our chair, and it was me and the nominated individual, Christina. As we were driving there, we realised that this person was double amputee, and we were like, how are we going to be able to use this? So Charles bought a transfer board, and since then we've had other amputees, and we can get them into a position where we can transfer them straight onto a chair or a bed. So yeah, it gets you thinking out of the box. you know, you don't want them in hospital. They don't want to be in hospital.
That's fantastic. I love it, and that's exactly the kind of message that we need to get across. Just one quick one on here. I have done, and the team here at Felgains, since the success of Ashley Care, we've reached out to a number of home care providers and explained the concept. And one of the big barriers that is often put up is that we have a company no lift policy, and that we wouldn't ever pick anybody up. Now, I've obviously got my answer to that, but I'd be interested to hear what your answer is.
Yeah, I would say 100% that has always been the mindset throughout care. Don't lift anybody up, and I completely agree. You're handling somebody that's probably very delicate. Their skin is like tissue. They bruise easily. So without the equipment, I would 100% agree that you do not lift anybody off the floor. And unfortunately, it would be an ambulance service and paramedics that have to do that. And that person might be absolutely fine, that needs no treatment whatsoever. So for us, we don't have to consider that. We have to consider whether the HelpFall app tells us we can lift or we can't lift. Yeah.
And I think that's even an interesting response in itself, in that you have recognised that a no lift policy is without equipment, whereas sometimes there's a perception in the market that no lift policy is a blanket no lift policy, that actually what you have to remember with a hoist, you're lifting somebody, it's without equipment. So Charles, you briefly touched on insurance and how that affects it, because that's another question we typically get, but you're saying you've notified them. Anything more to say on that?
Not particularly, Grant. Again, it's a case of this is standard practice, as Kerry just pointed out, and what you just reiterated. If you have the right tools and equipment and the right training, then this is something that can be rolled out.
Okay, I think probably my final question was, and something that sometimes comes up with an industry that's sometimes reputed as having a relatively high staff turnover, what can be done to sort of embed the innovation and make sure it lives on?
Yeah, I think that when you talk of, and Kerry can sort of add on to this, but there may be high staff turnover, but within your core senior team, there shouldn't be that high staff turnover. And I think that's one fundamental. I think if you put it within the policy, and if that's your process, then it shouldn't really matter who within your senior team responds to the visit. Then this should just be something that happens as an organisation level. I think there's multiple things we do as organisations, and it doesn't matter who's in post. Then they should be doing exactly as we've done previously. So it's a case of training, making sure everyone's up to date, making sure people are confident. If there are any reasons why people don't feel comfortable, acknowledge them, ensure that they have all the resources that they need, and then have that open discussion. And I think that's important to do. But Kerry, you might want to add on to that.
Yeah, our staff, they will ring the minute they find anybody on the floor or, you know, in a compromising position that will need assistance to lift. And they are just so happy that we get there so quick. We're able to help in most occasions. I would say as well, sometimes an ambulance crew gets there before us, so we don't always get to cancel the ambulance crew. But we might get there and they'll still say, do you think you can go and get your equipment and lift this person for us? So, you know, we still support them, and they allow us to do that using the chair and our assessment.
And that's kind of the proof, isn't it? Like, if the ambulance service are recommending that this is a great approach, well, then that's kind of the answer that we've been looking for. Just to wrap up then, Charles, what would you say anybody that's on the call here, maybe they're in a similar situation to you as maybe owning a care agency, what would you recommend a next step to be?
Well, hopefully today has given you all the information that you need, and hopefully you've seen the results and then the impact. And I'd say the next steps is to discuss with Grant. Again, you can reach out to me directly, and if you've got any queries about how we actually implement this, again, I'm sure that Kerry wouldn't mind answering any questions. And then it's just a case of moving forward and understanding if it fits your organisation. Again, it's always great to reach out to local stakeholders. That might be your local authority, that might be your ICS, discuss the innovation, see what benefits it could bring to your service. And also, fundamentally, people need to ensure that they're actually measuring the frequency of falls actually within their service. And I think that's one aspect that we haven't actually touched upon. But if you don't maybe know the propensity of people falling in your own service, that might be a starting point as well, to understand if this is something that could be hugely beneficial. So definitely measure that. Reach out to the team, reach out to Kerry or I, and if you've got any questions, yeah, always happy to answer them.
Yeah, that's good. This webinar will be turned into a video and circulated with the recording and any other resources, probably including the PowerPoint that Charles has shared as well. So we are at 1 minute 2, and I believe that brings us to the end of this webinar, and we trust that you have found it both beneficial and helpful, and we hope that we will end up talking again in due course. Thank you all.